Very good evening, everyone. So we are continuing the NEET SS 2025 recall. So here's my take. There is a mixed bag of questions, some from the general pediatrics, some from the neurology topic, right? So without further ado, let's start. Overall, the questions were not that tricky, I believe, and the difficulty of the question paper was close to moderate. So let's start. The first question is that the key principle in the management of hypernatremic dehydration is options we have are rapid correction, sodium correction, less than 10 to 12 milliequivalent per liter per day, free water bolus, or hypotonic saline only given. So we all know whether we are managing hypernatremic dehydration or hyponatremic dehydration, we don't have to correct the sodium rapidly. The sodium correction should be 10 to 12 milliequivalents per liter per day. That is option B. So option B would be the correct answer over here. Moving to the next question, which of the following features Which of the following features are most reliably differentiates von Grech from other glycogen storage disease? So when we are talking about von Grech, how is it different from other glycogen storage diseases? Because we all know which enzyme is affected over here. There is glucose 6 phosphatase deficiency, and because of that, we will have high levels of glucose 6 phosphate. These high levels of glucose 6 phosphate would be now consumed in the PPP pathway, that is the pentose phosphate pathway. So there will be higher level of production of ribose 5-phosphate, nucleotide synthesis, and degradation products like uric acid. And thus, hyperuricemia is something which is very unique to von Grech disease, right? So von Grech. So hyperuricemia is something which is unique. Hyperuricemia is something that is unique to this one, right, as compared to other glycogen storage diseases. Right. Moving to the next question, we have a 6-month-old child that presents with malnourishment and severe dehydration. This child is conscious, hemodynamically stable, and not in shock. What would be the most appropriate fluid management in such an infant? So, when they are telling you a 6 months old child who is malnourished, assume they are talking about a very severely malnourished child. So, management of dehydration in severely malnourished child, SAM children, is different from normal dehydration management. How it is different? The severe dehydration management here would depend whether this child is in shock or not. If not in shock, we prefer oral therapy. If in shock, then only we give IV therapy. So let's look at the options. We have 100 ml per kg IV fluids over 3 hours. No, we are not going to give IV. So the first two options are omitted. The option C is oral rehydration solution only. This is also omitted because we know the rehydration solution that we use in these malnourished children is not the normal WHO oral rehydration solution. It is Risomal, that is rehydration solution for the malnourished. So option D is correct, that we give Risomal based cautious rehydration over the next 10 to 12 hours. Moving to the next question, a burst suppression pattern on EEG in early infancy suggests very typical. In early infancy, if you see this burst suppression pattern, this is suggestive of Ohtahara syndrome, which is also known as EIEEE, that is early infantile epileptic encephalopathy. In West syndrome, you all know there's hips arrhythmia that we see. In Lennox-Gastaut, you see 1 to 2 heart spike and wave. In Dravet, we see polyspike wave and complex. So EEG patterns have been thoroughly discussed in our video lectures. Also, a separate section of these pediatric epilepsy syndromes is there, where we have summarized all of these conditions. So make sure you underline or make notes of these typical patterns that you notice on EEG. Moving to the next question, EEG again showing 3 heart spike and wave discharge. This 3 heart spike and wave discharge is very typical of absence seizures. So here we have 3 heart spike and wave discharges with E-tonic seizures. So that means this they are talking about atypical, atypical absences. So they're asking what drug would you prefer in such an atypical absence seizures. The options we have are ethosuximide, phenytoin, valproate, and carbamazepine. We all know drug of choice we considered ethosuximide, but ethosuximide is for typical absence seizures. For atypical ones such as atonic seizures, we would want a broader perspective, a broader coverage of anti-epileptic, and that would be valproate. That will be valproate. So valproate would be the best answer over here, right? Moving to the next question, we have a preterm neonate who is born at 28 weeks of gestation. This child develops hypotonia and has delayed motor milestones. The neuroimaging shows periventricular, bilateral periventricular white matter injury, which is again very consistent with the brain injury that we see in preterms, periventricular hemorrhage, germinal matrix hemorrhage. Later, it develops periventricular white matter injury. The child later develops spastic diplegic cerebral palsy. What is the most likely underlying mechanism? We all know the underlying mechanism here is because of this injury, what happens? The auto-regulation is lost. And because of that loss of auto-regulation, there is ischemia that leads to the cerebral palsy-like picture. So option B is the correct answer. There is failure of cerebral auto-regulation that leads to ischemia. Moving to the next question, ataxia, conjunctival telangiectasia, and immunodeficiency suggest a mutation involving which chromosome? Typical features ataxia, telangiectasia, immunodeficiency. This is nothing but ataxia, telangiectasia, and we all know the gene involved here is ATM gene. This ATM gene is present on chromosome number 11, right? So the correct answer here would be C, chromosome 11. Moving to the next question, a young adult presents with progressive dysarthria and gait ataxia. The neurological examination reveals cerebellar signs without pyramidal or sensory involvement. The brain MRI shows widespread cerebral atrophy with relative preservation of the brainstem and spinal cord. There is no history of telangiectasia, recurrent infections, cardiomyopathy, and scoliosis. Which of the following is the most likely diagnosis? So, just by looking at the options, spinocerebellar ataxia type 3, Friedreich ataxia, telangiectasia, and multiple system atrophy. We know this is a disease of elderly around 50 to 60 years of age. You're going to see this. So, let's omit this option. They're saying there's no immunodeficiency, no telangiectasia. So, ataxia, telangiectasia is also out of the picture. Dysarthria, gait ataxia, all of these are consistent with my Friedreich ataxia. Right, so the correct answer here is going to be B, Friedreich ataxia. Friedreich ataxia has cardiomyopathy, so it is the best option. AT was omitted out, and multisystem atrophy is also omitted out. So moving on to the next question, we have a 15-year-old child that has history of tremors and dystonia for more than 10 years of duration, right? So it is a 15-year-old child. For more than 10 years, this child is having tremors and dystonia. And if you look at the total serum bilirubin over here, that is 30. What would be the most likely diagnosis? The options we have Gilbert, Rigler-Najar type 1, Rigler-Najar type 2, and Dubin-Johnson syndrome. What would be the correct answer over here? Longer duration and high bilirubin levels. So such a picture is consistent with type 2 of Rigler-Najar. Option C would be correct, right? Option C. Moving to the next question, we have a 12-year-old child who is brought with the complaints of bad temper and outburst that is out of proportion to the situation since 12 months. And the behavior has been noticed by both home and school. What would be the most likely diagnosis? So this temper tantrums that is present in more than two situations for a period of 12 months. This fits better to disruptive mood dysregulation disorder, option D. Right? In autism, ADHD, in autism spectrum, there would be some communication problems, expression problems that is not given over here. In oppositional defiant disorder, the criminal offenses would be much more. evident. And in ADHD, inattentiveness and hyperactivity would be the part of the stem. So most appropriate here out of all the options would be DMTD. Drug not used in Dravet syndrome. Lamotrigine, valproate, stiripentol, clobazam. Since NEET PG days we are learning about this. We all know which channel is affected in Dravet syndrome. It is the sodium channel SCNA1. And because of that, we do not give lamotrigine, carbamazepines, all of these drugs because they act on the sodium channel. So the correct answer here is going to be lamotrigine. We don't give lamotrigine, carbamazepine, and phenytoin because they all have sodium blocking action, and Dravet syndrome has a defect in the sodium channel only. Moving to the next question, a child presents with jaundice, triangular faces, and butterfly vertebra. It is a classical picture of which syndrome? This is Alagille syndrome, and they're asking what is the cause of jaundice here in the Alagille syndrome. We all understand that in Alagille syndrome, there is paucity of the intrahepatic bile duct due to which the child has jaundice. So the correct answer here is going to be B, paucity of intrahepatic bile ducts. Moving to the next question. We have a 9-year-old child with Down syndrome who went to a barber for a haircut. Soon after, the child developed neck pain and headache, followed by difficulty in walking. On examination, there is neck stiffness, exaggerated reflexes in all the four limbs. What could be the underlying cause of this presentation? Down syndrome patients specifically, they have higher chances of developing these atlantoaxial dislocation because of ligamentous laxity, right? That's why even if they are asymptomatic, we go for screening by using a neck x-ray so that we can pick up this dislocation earlier, right? So the correct answer here is atlantoaxial instability due to ligamentous laxity. Next question. A 10-year-old child with traumatic brain injury has signs of raised ICP. An intensivist instructs the team to avoid hypercapnia during ventilation. What is the most appropriate physiological reason? We all know what does hypercapnia do? Hypercapnia will cause cerebral vasodilation, and that cerebral vasodilation can further increase the blood volume in the cerebrum in our intracranial space and further increase this intracranial pressure. We don't want that, right? So the correct option here is going to be this option B. Hypercapnia causes cerebral vasodilatation, increasing cerebral blood volume and raising ICP. That's why in the management algorithm of raised ICP also, we allow permissive hypocapnia. We want washout of CO2 so that there is cerebral vasoconstriction and reduction in the cerebral flow. Next question, we have a 2-year-old child who has history of delayed meconium in the neonatal period and now present with chronic constipation. So most likely it is Hirschsprung. Let's read the other stem. On DRE, digital rectal examination, the rectal wall is empty again, pointing towards Hirschsprung, and withdrawal of the finger is followed by forceful expulsion of gas and stool. The best way to confirm this, we know the screening tool, we use anorectal manometry, but the best way to confirm is to do a rectal suction biopsy. On biopsy, we see that there is absence of the ganglion, hypertrophic nerve fibers, and positive staining with acetylcholinesterase. Right, so this is confirmatory for Hirschsprung disease. The correct answer here is going to be C, rectal suction biopsy. Moving to the next question, which fluid you should use to replace nasogastric aspirate? For nasogastric aspirate or any gut aspirate, we replace it with NS with added potassium. So the correct answer here is going to be NS with 20 milligram per liter of KCl. Next question, we have a 5-year-old who has history of passage of bloody stools. He's also anemic and otherwise normal appearing child. Which investigation you want to do? Remember, whenever you have a apparently normal looking child with bloody stools, anemia, we have to rule out Meckel's, right? So the correct answer here is going to be Meckel radionuclide scan, option D. Moving to the next question, we have a SAM child who is being evaluated. Which of the following factor decides if the child needs an hospital admission or not? So whenever we encounter a SAM child, we make sure, how do we manage? We look for any complication. If it is an uncomplicated SAM, home-based management can be done. If it is a complicated SAM, then we go for hospital management. So how do you differentiate the two, complicated and uncomplicated? In a complicated SAM case, the appetite test would be failed. The child would have poor appetite. Also, there can be edema, severe edema. Also, there could be medical complications, danger signs, and uh, and thus this child needs hospital admission and management for the same. So looking at the options, presence of severe wasting, that is the definition of the SAM. Wait for length, again, wasting is a factor that is already given in the question paper. So we have two options, medical complication and edema. Technically, both of these point towards complicated SAM. But better would be option C, that is medical complication or IMNCI danger signs. Next question, we have a child with the recurrent respiratory infections and failure to thrive. For which condition the child should be evaluated first for? The options we have are primary immunodeficiency, congenital heart disease, TB, and HIV. A child with recurrent infections in FTT, you go for checking for primary immunodeficiency, right? Moving to the next question, which porphyria presents with neuropsychiatric symptoms and abdominal pain without photosensitivity? Yet another basic question, such porphyria is AIP, that is acute intermittent porphyria. In this, there is no photosensitivity, but the child commonly presents with neuropsychiatric manifestations and abdominal pain. So with that, we complete the section of my take on NEET SS 2025 recall. So with that, let's end this session. Thank you.